necrotic pulp. And histologically, it's either a cyst or a granuloma, and we don't believe that we care if it is a cyst or a granuloma, because we believe that we can heal both a cyst and or a granuloma. So that begs the question, what is the interest that endodontists or people doing endodontics have in the vital tooth? And the answer is very simple. If you have a vital tooth, you will not have this disease. So that's the prevention of apical periodontitis. So when we're talking about a vital tooth, we're talking about preventing apical periodontitis. When we're talking about a necrotic tooth with apical periodontitis, we're talking about healing apical periodontitis, which is much more difficult than preventing. It's exactly the same throughout medicine. You know, it's harder to treat cardiac disease than to prevent cardiac disease. It's harder to treat periodontal disease than to prevent periodontal disease. And it goes on and it goes on and it goes on all the way through medicine, right? So when we talk about prevention, we're talking about the vital pulp. And actually the vital pulp, in a broad sense of endodontics, is two-pronged, if you will. The best root canal filling you could possibly dream about is a vital healthy pulp. A vital pulp is non-infected and it fights to stay that way in a bioactive way, if you will. So the best possible endodontic treatment one could do is to maintain the vitality of the pulp. And I have a lecture on this series, and you will see that lecture. And that lecture is on the expanding role of vital pulp therapy, because we are able to, with new technologies, with new understanding, with new materials, we are able to maintain the vitality of the pulp to a much greater degree. And that is very exciting and bodes well for the future of endodontic treatment. Now, failing that, in the diagnosis of irreversible pulpitis, and you will again have a lecture in this series on diagnosing pulp disease and the difference between reversible and irreversible pulpitis. But when we have a diagnosis of irreversible pulpitis, what we're assuming, number one, is the pulp is vital and generally clinically non-infected. And number two is, if we take out that pulp and do root canal treatment because it's irreversible, if we use a technique which will not put microbes into the root canal system. In other words, we use an aseptic technique, and that's what you would learn if you came to our hands-on courses, because asepsis is absolutely key for this aspect of endodontic treatment. If you use an aseptic technique, you will have a very, very high predictability of success in treating a vital tooth, as was seen both in the university-based studies and in DeBellion's case series. So actually, when you say vital tooth, this is of interest in terms of clinical, because the tooth is alive. We have to give good anesthesia so the patient is comfortable and likes us and will tell their friends, and we'll have a successful practice. But from a biological point of view, what we're interested in and sort of excited about is this is a non-infected pulp, particularly the root pulp. There could be some infection where there's an exposure or something like that. And the fact that this is a non-infected pulp makes this a more simple, not easy, but more simple procedure biologically. And the biological principle is quite frankly, asepsis. So with asepsis, you will have a successful result. So in terms of the first part, the expanding pulp therapy, as I said later in the series for this lecture, you will have a lecture on the expanding role of vital pulp therapy, and we can get some amazing results. You have a exposure, which until recently was considered to be a definite indication for a pulpectomy. We can do partial pulpotomy on one root, the distal root, and a full pulpotomy on the mesial root. Admittedly, this was not thought of beforehand. It just happened that way. But in a 1.5 year follow-up, you see no apical periodontitis. The patient is asymptomatic, and you see a hard tissue barrier on the distal aspect of that pulp, indicating that the pulp has stayed vital and is healing itself. So we can do things that we never dreamed about by using materials like bioceramics and good coronal seals, etc., etc. So this is the first aspect, or the best part of maintaining vital teeth, is to keep the root pulp vital as your root filling material, and that's the expanding role of vital pulp therapy. Failing that, as I said, if we do a pulpectomy, asepsis is our principle. Easy to talk about, easy to write in a textbook chapter, but actually quite difficult to do in your clinic, even if you use basic principles of a rubber dam, sealing the rubber dam, etc., etc. And I know, based on the literature, based on my experience, that the rubber dam is not generally used in practices of general dentists. And it's absolutely fundamental to asepsis, and asepsis is absolutely fundamental to a high success rate for treating a vital tooth. So again, I go back to the fact that in dental schools we teach it incorrectly. We teach if you don't put on a rubber dam, you don't get a signature. We've got to teach that if you don't put on a rubber dam, you won't get success. Doesn't matter where you do the root canal. I remember I graduated dental school in 1976, and my first few years there were no gloves for dentistry. So I mean, I used to go home, and based on the saliva marks on my hands, I knew how busy I was that day. And then when gloves were mandated, for asepsis, or to prevent disease, I thought my endodontic days were over. Today, I don't think with a gun to my head I would be able to put my fingers in a patient's mouth without gloves. And this is what we have to teach, and you as the audience and dentists have to understand that you cannot get predictable success if you've got saliva inside a root canal. And particularly tragic is if there are no microbes before you start. And now, because of you, the practitioner, microbes have been able to get into the root canal. That is why in private practice we get 50% success, and in a university-based system where the students are totally inexperienced and don't know what they're doing, basically, they are able to get 95% success. So I cannot stress enough the importance of a rubber dam, sealing the rubber dam, removing all the caries, etc. And then I could give another lecture, but a lecture is actually a very ineffective way of doing it. You have to see it yourself. You have to learn how to pass the instruments without contaminating, etc., etc., etc. So again, I'm going to spend most of the rest of the time on the treatment of apical periodontitis, which is the challenging one where you have microbes in the root canal system, and then just sort of point out the differences and where you could shorten the treatment procedure slightly if you're talking about a vital tooth. So the treatment of apical periodontitis is basically the treatment of an infected root canal system. And we're going to approach this from a biological approach, as I've said before, and then a clinical approach using the new technologies. And this is pretty difficult because the new technologies are coming out every day. And I'm into endodontics as a full-time career, if you will, both doing it and teaching it, and I can't keep up with the new systems. So you know, this is very, very difficult to keep up with, but our aim is to give you such a good biological basis that when a new technology comes out, you will be able to evaluate it as compared to what you're using now and see if this is going to help you. Okay? So to me, the analogy I use is the technology is the evolving GPS system that we all use in our cars, and these, as you know, are evolving daily. They're getting better daily. They can tell you the easiest way home, the quickest way home, the least amount of traffic. But unless the GPS system knows where home is, it's absolutely useless. In other words, without an address, all this new technology is absolutely useless. So the biological basis is your address, and the new technologies are the way to use and to quickly and to efficiently get to that end point. And we are going to, in this course, and particularly if you choose to come to the hands-on aspect of the course, we will teach you the new technologies that we promote. Not to say that other technologies cannot work just as well. So when we're talking about an infected tooth, the entire canal has become infected, and now the inflammation has extended or popped out, if you will, into the periapical areas. And now everything favors healing, because when it was inside the pulp, the microbes could refresh themselves, attack the pulp, refresh themselves, attack the pulp. The pulp is sort of confined to the root and a very non-compliant small area, and ultimately the bacteria are able to overcome the defenses of the pulp. When the microbes now pop through into the periradicular tissues, everything favors the periradicular tissues, because the microbes now have to squeeze through very small foramina, accessory canals, lateral canals, etc. The volume is decreased, etc. And then the jawbone has unlimited blood supply and the ability to adjust according to the insult. So if not such pathogenic microbes are coming through, or not such a high volume of microbes are coming through, you get a small radiolucency. If the microbes are pouring through at a high volume, you'll get a large radiolucency. And that radiolucency is the body's way of defending itself. That's an inflammation, a periodontitis. Now, by definition, a periodontitis or any inflammation can heal and become normal tissue again. So as long as, or as soon as we as dentists go in there, lower the microbial count to the extent that the body is able to heal and become normal again. May not become completely normal, because we as dentists may not be able to get rid of every last microbe, but now a very, very, very small volume is going through the periapical tissues, or dealing with it to the extent that enough normal tissue can regrow that we on the periapical radiograph look at it and say this is healed. And obviously the patient is asymptomatic, and we tick that off as a successful case. So if we think about it, asepsis is our key for the vital tooth. Very simple to say, not so easy to do, but that is the key for success in a vital tooth. And asepsis and antisepsis, not really a very good English word, it comes out of a Swedish textbook, but we really mean disinfection, with the aim ultimately of sterilizing the root canal, is the key for a tooth with apical periodontitis. And we have to understand that at the moment we get 95% success with periapical radiographs. If you took the same cases and did CBCT or three-dimensional radiographs, we probably would have a lower success rate, and with histology an even lower success rate. But as we improve with antisepsis or disinfection and get closer and closer to sterilization of the root canal, so the success rate will get better and better and better with every type of monitor that you think about, CBCT or histology. So, as I've tried to say, the threshold of microbes is there. So there are microbes. We expect that there are microbes. But if they're below a certain threshold, then patient doesn't feel the effect and we don't see the effect on the radiograph. Now when the threshold goes, when the microbes go above the threshold, then either the patient starts to feel, or more likely we see a radiolucency, and only in 30% of the cases the patient feels as well. Now this is a very important picture to have engraved in your mind, because now we sit down with the patient and we start our root canal treatment. And the first stage of root canal treatment is the microbiological stage, or the microbiological stage, microbiological control, if you will. So our job now is to sit with the patient and at our choice for the next 20 minutes, 30 minutes, 45 minutes, 1 hour, 1.5 hours, using 1 file, 6 files, multiple antibacterial protocols, etc. But our job is very simply to get the threshold, get the microbes below that threshold. If we can get the microbes below that threshold, then the lesion will heal. If the lesion heals, it is assumed, and in almost every case, the patient is asymptomatic. And then we do a root filling and a coronal filling or top filling above that, either the same visit or the second visit. We'll discuss how we do it, and that is designed to maintain the environment below the microbial threshold, and it's maintained to it's designed to maintain it for the rest of the patient's life, assuming we haven't done anything that will jeopardize the functionality of that tooth. So this is the important stage, and we have to understand that the success in endodontics, when you take a 1-year follow-up, when you take a 4-year follow-up, when you take a 15-year follow-up, when you take a 40-year follow-up, will depend on how much effort we placed, how much we understood, and how much we were prepared to do in order to get the microbes below the threshold. And then, to a much lesser extent, the root filling and the top filling was just as important in maintaining that environment. If we fail to do it, the lesion will not go away, and we will consider that to be an unsuccessful case. If we succeed to do it and our top filling and root canal filling is inadequate and starts to leak over time, then it may heal and the lesion would come back again. So, unlike the vital tooth, where the challenge is anesthesia, but biologically there's very little challenge, in a necrotic tooth, the challenge is not anesthesia. In fact, some people, not me, but some people choose to do the root canal treatment without anesthesia, but there is a tremendous challenge biologically in removing enough bacteria or enough microbes or microbial byproducts so that we are below the threshold for the life of the tooth, for the life of the patient. So less microbes, which is our aim, means better healing, means a better prognosis. Now we must never think that, okay, less microbes, but we cannot get rid of all the microbes, therefore microbes are not important. That's absolutely not true. We have to understand, as with everything else in life, we live in the gray area and there's no perfect and, you know, a complete failure. So we absolutely aim for less microbes with every treatment we do, with every technological advancement that we make, with every technological advancement that you as the dentist agree to use in your practice. So endodontics is microbial control. It's as simple as that. In vital teeth, you're preventing microbes. In non-vital teeth, you're removing microbes. Progress in endodontics is more efficient control of microbes. Okay? Endodontics is not a preconceived look, and that preconceived look is generally the look we've had for the last 40 years from stainless steel files with all the limitations of stainless steel files. So we were only able to get to very small sizes in the last 3 millimeters. And we started to get that in our minds as an acceptable root canal. If you've got that, then you can start decreasing the number of files, etc., 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 decreasing the time, but actually you're doing nothing for your success rate. So we have to understand that we need to use the new technologies to remove more microbes, not to make the treatment quicker. All right, so now we're going to look a little more deeply at where the microbes are that we're trying to remove so that we can form a strategy on how to predictably remove these microbes. So there's one bit of very, very good news, and that is that 90 to 95% of the microbes are in the main canal. And actually the next slide will show that these 90 to 95% of microbes are planktonic microbes, and that means they're swimming loose in the root canal, and these are the microbes that go outside the accessory canals, the foramina, etc., and challenge the periradicular tissues. That's very good news, because theoretically you could wash these microbes out just with a fluid, a liquid. And we don't have to have sophisticated instrumentation techniques. We don't have to have all these other things, because these are swimming bacteria. You don't even need an antibacterial. I only wish it was that simple and that easy, but from a theoretical point of view, we could wash these microbes away. So 90 to 95% are inside the root canal, planktonic bacteria which are communicating with the periradicular tissues. Now there are, particularly in the apical part, many accessory canals, many lateral canals, and these obviously are much more difficult to get to. And we're going to use, for example, I'll discuss chlorhexidine as an antibacterial, because that is an antibacterial that moves through the dental tubules and moves through very small spaces much more effectively than the other irrigants. But the good news, if you will, is that these are so tight and so small that very often the volume of microbes is so small that the periradicular tissues can handle them very easily with very little inflammation, which is usually subclinical. As I said, the microbes in the tubules are interesting. In the vast majority of the root, the cementum is intact on the outside of the root. And if the cementum is intact, then the microbes can only go about 100 to 300 microns into the root canal system. So this is very, very little, less than 1/3 of a millimeter. So one good scrape of the dentin and your microbes are removed. The challenge, again, as I mentioned right at the beginning, the challenge is in the apical 3 millimeters or so. And that is when you have apical periodontitis, you get cemental resorption, and in many areas the cementum is completely removed and you get dentin exposed. And as soon as the dentin is exposed, now the microbes can move all the way out to the external surface. And this could be 800, 900, 1,000, even 2,000 microns, 2 millimeters, if that's thick, into the external surface. And this is a major challenge. And again, one of the reasons why for infected teeth only, we use 2% chlorhexidine in order to try to take care of these microbes. These are obligate anaerobes because it's very, very small space and no oxygen in the area. And these obligate anaerobes are predominant in the tubules and in the apical 3 to 4 millimeters of the root canal. The isthmuses and communications between the main canals is also a challenge. We rely on irrigation, we rely on adjuncts to push the irrigants into these areas. The only good news in this is that if we seal the main canals well, we generally can trap those microbes into the areas that they are, and those microbes will not communicate with the periradicular tissues through the apical foramina, accessory canals, etc. The problem with them is they're communicating between the canals. So if you've cleaned one canal very, very well and left another canal with substandard cleaning, if you will, that substandard canal will keep feeding microbes into the second canal. So these communications are a challenge, but we can overcome the challenge by sealing the main canals very well. Now, the most important and difficult challenge we have in root canal treatment is the fact that when you have an infected root canal, actually the inside of the root canal has a biofilm layer on the surface of the root canal. And this is not dissimilar from periodontal disease, marginal periodontitis, where we have plaque which is on the external surface of the root canal. Now we don't really have examples of the plaque becoming calcified like calculus, but certainly we have the biofilm similar to plaque. And the problem here, of course, is that plaque and biofilm in general is very, very difficult to get rid of. And as you can see from the slide, 1,000 times more difficult to remove than those swimming planktonic bacteria. And if we take our periodontal colleagues' experience, we will make the statement that you cannot get rid of biofilm unless you scrape the walls. And to this day, our periodontal colleagues still agree that you need to scale and root plane the external surface of the root before you can expect the irrigants and disinfectants that we use to be totally effective. The bacteria basically have to be exposed by physical movement of a scaler and root planer, if you will. So if we take that to the internal surface of the root, we need to scale and root plane the internal surface of the root, which sounds reasonable and it sounds easy, but our big problem is that the root canal is not round. And with a non-round root canal, you need very specific instruments to clean and scrape and scale the internal surfaces of the root. And to this point, recently it has changed, which I'm going to discuss when we get into the technical aspects, but to this point, endodontic instruments make a round diameter. Doesn't matter what instrument you use, whether it's stainless steel file, O2 taper, this company's files, that company's files, O2, O4, 6 taper. Basically, you're making a round diameter of your root canal. And this doesn't fit a non-round canal. So it's very, very difficult to safely scrape the biofilm from a root canal. So here you have again a picture of the biofilm, which is 1,000 times more difficult to remove compared to the planktonic bacteria. So when we think of disinfection and we think of adequately lowering the microbes and microbial byproducts to below the threshold, we have three basic aims here. The first is to mechanically scale, and we're stealing that word from our periodontal colleagues, mechanically scale the internal walls of the canal to disrupt as much biofilm as possible. Secondly, we are going to come in with a chemical to both physically wash away those microbes, both the planktonic microbes and the exposed biofilm, where the microbes have become planktonic. And then the third thing is we want to prepare for our root canal filling, and then of course place a top filling on top of that. So that is the first aim, and that is what we're doing in that first visit, where we're taking microbes which are way above the threshold and trying to get the microbes below the threshold. So let's take these one at a time, if you will. In order to scale and root plane the internal surface of the root, we have to have some idea of their dimensions. So if we look at a root canal and take the apical 3 to 4 millimeters, you've seen this slide before. We've got our cemental cap, we've got our dentin, and we've got the cemento-dentinal junction, and generally we're aiming for the root canal to finish at the cemento-dentinal junction. So the first point I've already made is that is usually 1 millimeter short of the end of the root, both physically and radiographically. Second thing to understand, that in 25% of cases, the best example I can give you is a lower incisor, mesiobuccal of an upper molar. In 25% of these cases, the long diameter of the root is more than twice the short diameter of the root. So this is a problem, not because of the root shape. Of course, we can take the largest diameter and machine a round shape into that root canal, and that will give us cleaning and scraping of the biofilm throughout the root canal. The problem actually is that the canal shape is a miniature of the dentin shape or the root shape. So if I do what I described previously and machine out a round shape in that root canal, I'm going to run out of dentin mesially and distally corresponding to the narrowest diameter. And particularly if I start to move the root canal with my endodontic files in one direction, then I'm really going to jeopardize the functional success or the long-term stability of this endodontically treated root. So this is a huge problem, and in these 25% of cases, I would say it's impossible with a round instrument to clean the entire root canal. Now, in the other 25%, other 75%, remember those previous ones were 25%, we can get closer. I'm not sure we can do it perfectly every time, but we can get a little bit closer. And the key factor there is to keep our instruments centered in the canal and not to move the instrument or the filing favoring one side as opposed to another. So we look at a lower molar in a review article by Vitucci, and I like to use the lower first molar because this represents small canals in the mesial canals, representing any small canal in the mouth, buccal canals, two-canaled single root, etc. And we've got a big canal in the distal canal, and that represents canines, central incisors, etc. in the rest of the mouth. And if we look at this tooth from a dimensional point of view, let's look mesiodistally, which is what we see on the X-ray. We look 1 millimeter from the end of the root, which corresponds to the cemento-dentinal junction, and then 2 millimeters and 5 millimeters. And then after that, it's not even worth measuring because most canals have different tapers, and you know, by brushing we can adequately scrape those walls, and we can really do a relatively good job on the biofilm. And as I said before, the coronal 2/3 is not our major problem from a microbiological point of view. So let's look mesiodistally at the mesiobuccal and the mesiolingual. And what you see is the small diameter, mesiodistal diameter, is 0.21 or 0.28 in length, in diameter. Which means that if I instrument a root canal and finish at 0.25, which is a size 25 at the apex, I will have an X-ray that looks adequate. It'll look like a decent root canal, and it will be exactly the same as what I used to do with my step-back shape with stainless steel files. Okay? On the distal, that size to look adequate on the X-ray would have to be a 0.35. Now, unfortunately, if you turn the tooth around to the dimension we don't see on the X-ray, and that's the buccolingual dimension, actually, to get maximal cleaning of the biofilm, you have to go to 0.40 or 0.38, which is the closest is 0.40, which is a 35 or 40 in the mesial or small canals, right? And in the distal or big canals, you need to go to about a 50, or in some cases even larger, 55, 60. So I don't think the question is, should you go to these larger sizes? The question really is, can you go to these larger sizes safely? And we believe, and we're going to attempt to show you, that you can go to these larger sizes safely if you use the nickel titanium technologies correctly and not just to decrease the number of instruments you use, etc. So if we look at this diagrammatically, here you have a non-round canal, which is basically every canal, to some to more of an extent than others. If you instrument to the minimum diameter, which is a 0.25, which is actually the most popular size promoted, if you take a radiograph, it's going to look fine. Very attractive to do this. Easy to do. You're going to have less challenge, and if you have less challenge, you have less mistakes. It's going to look great on the X-ray, and the industry loves it, because if you're not really doing much and instrumenting only air, if you will, then why do you need 6 files to do that? You can do it in 3 files, 2 files, 1 file. So if you're going to do nothing, I'll promote to you to do nothing with my 1 file system, and as long as you don't understand the biology as a dentist, you'll be attracted to that 1 file system. You'll buy the 1 file system. You'll be happy because your radiograph looks okay. Industry will be happy because you're buying their files. The periapical tissues won't be too impressed. So if we're thinking biologically again, let's go to the maximum diameter. Sounds attractive, relatively easy to do, but functional success will be a disaster. You're going to get perforations, you're going to get strip perforations, and ultimately that tooth will fracture or will be unrestorable or difficult to restore, and the restoration will fail. So this is clinically unacceptable. So for the last 30 years, we as a Penn philosophy, if you will, or wherever we've been, when I was at University of North Carolina for 15 years, it was a North Carolina philosophy, we basically went to the maximal safe apical sizes. And what we meant by that was we acknowledge that in many cases we cannot get to the, absolute criteria of scraping the entire wall, but we had a ratio and worked out what sizes you had to go to be close in most cases, and what sizes you had to go to where we felt you could do it safely. And that's what we came up with, the maximal safe apical sizes. And then with the acknowledgement that you can't touch the wider cases in 25%, wider dimensions, I'm sorry, in 25% or even more of these cases, we use adjuncts. And the most common adjunct used, I think, today is ultrasonication as an adjunct for getting to the areas where the main file cannot get to. Endovac is a negative pressure system to increase the volume of irrigant, which is quite effective against the planktonic bacteria. I'm a little bit skeptical with the biofilm. And this XP Endo, which I'm going to show you, is in the new wave of endodontics, if you will, of three-dimensional filling. So we have a wave of endodontic technology which is directed at scraping the walls in a three-dimensional fashion, and this is the one we're very excited about, and I will explain that to you a little bit later. So in terms of mechanical instrumentation, we come to recommended sizes, and basically what we recommend is what I've already discussed. In a small canal, 35 or 40